Now let's explore Anderson-Tawil syndrome, ATS. This one sounds really interesting, a rare condition that presents with a very specific triad of features.
That's right. ATS, sometimes called Anderson Cardiodysrhythmic Periodic Paralysis, is another rare autosomal dominant channelopathy, estimated at 1 in 1 million. Very rare. It's historically classified as LQTS type 7, but it's really unique because it's characterized by that triad. Episodes of periodic paralysis, ventricular arrhythmias, and distinctive facial or skeletal dysmorphisms. It was first identified back in 1963 with further description of the classic triad by Ellen Anderson in 1971. Significant advancements came later, particularly from Robbie Tawil in 1994, hence the name Anderson-Tawil syndrome.
What causes this unusual combination of symptoms? Muscle weakness, heart rhythm problems, and physical features, how are they linked?
So ATS has an autosomal dominant inheritance pattern. Type 1, ATS1, which accounts for about 60% of cases, is caused by mutations in the KCNJ2 gene. This gene encodes the KARE2.1 inward rectifier potassium channel. This channel is vital for maintaining the resting membrane potential and for repolarization in cardiac myocytes or heart muscle cells. Mutations here reduce this potassium current, which prolongs repolarization and predisposes to ventricular arrhythmias. It also affects muscle function, causing the paralysis. Type 2, ATS2, comprises about 40% of cases, and these individuals lack KCNJ2 mutations. Its genetic basis remains uncertain, although another gene, KCNJ5, has been proposed. The electrophysiological hallmark is impaired potassium ion flow, leading to delayed repolarization. However, and this is key, unlike classical LQTS, QTC prolongation in ATS may be mild, intermittent, or even absent. The classic triad includes those arrhythmias, periodic paralysis, and physical anomalies. Cardiovascular symptoms commonly include palpitations and syncope, and disturbingly, sudden cardiac death has been reported in about 50% of patients. That's a huge risk.
Periodic paralysis typically presents at a very young age, often preceding cardiovascular symptoms by approximately 2 years. This paralysis and accompanying muscular weakness is not directly dependent on potassium levels, though it occurs more frequently in patients with hypokalemia, low potassium. The duration of these episodes is highly variable, sometimes lasting up to several days. Craniofacial anomalies include things like low-set ears, wide-set eyes, and a hypoplastic mandible, or small lower jaw. A long, narrow head shape called scaphocephaly has also been reported. Skeletal abnormalities include clinodactyly of the fifth digit, that bent little finger, sydactyly of the second and third toes, fused toes, and scoliosis, curvature of the spine. Not all individuals exhibit the full spectrum, though. Some neuropsychiatric associations like ADHD and depression have been suggested but are still unconfirmed.
Okay, given the potential for a normal QTC, what are the specific ECG clues for ATS that doctors should really be zeroing in on?
That's the critical point. Since the QTC might not be long, you need other clues. Studies identify several crucial abnormalities. Prominent U waves in leads V2, V4 are a big one. Bidirectional ventricular tachycardia is another very specific and dangerous rhythm. And frequent premature ventricular contractions, PVCs, are common. While there's ongoing debate about the QTC duration itself, earlier studies sometimes included the U wave in the measurement, suggesting prolongation. Many recent authors argue the QTC itself often remains normal, but the QU interval, measured to the end of that prominent U wave, is prolonged, averaging around 655 meters. Importantly, arrhythmias can occur independently of marked QT prolongation. One study showed 50% of patients had polymorphic ventricular tachycardia on Holter monitoring, underscoring the syndrome's arrhythmogenic potential regardless of the measured QTC. Beyond the standard ECG, additional investigations include Holter monitoring to detect arrhythmias, checking baseline and symptomatic blood potassium levels, and assessing thyroid function. While about 65% of ATS patients have a normal echocardiogram, others exhibit diastolic or systolic dysfunction. Electromyography, muscle MRI, and biopsy can help differentiate from other neuromuscular disorders. And of course, genetic testing can confirm the diagnosis and aid family screening.
So, how is ATS diagnosed definitively? What's the checklist?
Diagnosis is considered when at least 2 of 4 criteria are met. 1. Periodic paralysis. 2. Cardiac manifestations like those ventricular arrhythmias, a prolonged QTC, or prominent U waves. 3. Dysmorphic features, you need at least 2 specific ones like low-set ears, wide-set eyes, small mandible, fifth digit clinodactyly, or syndactyly. Or 4. A family history of confirmed ATS. It's important to differentiate ATS from other forms of LQTS like Romano-Ward and Timothy syndrome, and also from catecholaminergic polymorphic ventricular tachycardia, CPVT. As a genetic condition, there's no cure. Management focuses on symptom control. Arrhythmias, periodic paralysis, and syncope are treated with pharmacotherapy like beta blockers, calcium channel blockers, or flecainide. ICDs are indicated for patients with a history of cardiac arrest or sustained ventricular tachycardia. Periodic paralysis can be treated with carbonic anhydrase inhibitors like acetazolamide and potassium supplementation. Medications that prolong the QTC should definitely be avoided. Competitive or strenuous sports are discouraged due to arrhythmia risk, but light physical activity is actually encouraged, as it may reduce paralysis severity.